Thank you. I'd just like to begin and say it's a great privilege to be invited to talk in this setting where there's the who of LFS and P53, but also the people who motivate us to do what we do on a daily basis, namely the families. So thank you very much for the invitation. Reproductive factors in breast cancer risk is a question that comes up very often, especially in our screening clinics, where this is not going to answer every question that the women in the audience with LFS have. This is kind of a first pass at what we were able to see within the cohort of the NCI. So just a quick overview of the NCI cohort. We are mostly a self-referral or a physician referral study where participants and families can call in to the referral nurse who kind of gets more information about the family. If they're deemed eligible, they fill out questionnaires about the family history and each individual's medical and surgical history and cancer history. They become a part of the field cohort, which is families in the field who we're in contact with for follow-ups. We get medical records pathology, we do telegenetics and counseling, and also obtain biospecimens in the field. And a subset of this field cohort is invited to come to the clinical center for the comprehensive cancer screening. So as of April 2018, we have about 190 families enrolled with over 800 consented participants. Remember, we are a family study, so we enroll not only those affected with LFS, but also their family members who are interested to be part of the study. We've screened 134 individuals at least once. A majority of these have been seen at least 3 or 4 times at the NIH for screening. But I must note that we are currently not bringing in new families for screening while we are continuing to enroll families into this study. Telegenetics and counseling, education, and testing is a very robust part of the study. We've counseled over 150 family members of carriers of variants and tested 133. So in part of the questionnaires that are mailed out to participants includes demographics, medical surgical history, cancer history, including their diagnosis management and where this was done, basic lifestyle questions, cancer screening, if they're obtaining any screening outside of the NIH, female reproductive factors and prophylactic surgery, and importantly, a psychosocial evaluation. So today's analysis will be focused on participants' responses to the female reproductive factors. These are the questions that are asked. These are the things that questions are asked about in the questionnaire, is including the age at first menstrual period, pregnancy and childbirth, number of live births, lifetime duration of breastfeeding, use of oral contraceptives, menopause, fertility issues, and any history of hormone replacement therapy. Today, I'll be focusing on some of these. So our objective was to evaluate any possible association between the female reproductive factors reported by women in the study and the risk of breast cancer. We used the IIQ self-reported data in women with a confirmed germline P53 variant, excluded breast sarcomas, malignant and benign phyllodes for this analysis, and validated diagnoses with pathology reports or medical records. So 154 women were deemed eligible for this analysis. Of these, at study entry, 86 of them had developed at least one breast cancer. The median age of diagnosis is 32, which goes very well with what has been previously reported in LFS breast cancer literature. 13 of these had bilateral synchronous breast cancer. 19 of the 86 went on to develop a subsequent breast cancer at the median age of diagnosis of 40. 60% of the reported breast cancers in our cohort were ER/PR positive, and 57% were HER2/neu positive. So just to go into a few of these one by one and what our results showed. So in the IIQ, the individual information questionnaire, we ask about lifetime duration of breastfeeding. And what we saw in summary was that regardless of duration, breastfeeding in women who had at least one live childbirth was associated with a reduced risk of breast cancer. And just looking at the numbers, it seems that this effect is a little bit more significant with at least 7 months of lifetime breastfeeding. And here we see this visually represented, where along the y-axis we have what's called a hazard ratio of breast cancer, and on the x-axis is the lifetime breastfeeding months. And if you see here visually, just in the graph, you'll see a little bit of a dip here at 7 months of lifetime breastfeeding, and numerically this is the hazard ratio and the confidence interval associated with that. And here we have the hazard ratios for each month of breastfeeding. When we look at childbirth as an independent risk factor, so for those who are not familiar, nulliparous means that a woman has had no live-born children. In our study, parity typically means a viable pregnancy. For our study, the way the data was collected, we defined parity as at least one live childbirth. So nulliparous women were women who had never had a live childbirth, does not mean that they were never pregnant. And parous women were at least one live childbirth. So when we look at parity or childbirth as an independent risk factor, this does not take into account any of the breastfeeding details. What we see is that there does not seem to be an effect on the breast cancer risk within this cohort. This is a time-dependent variable, and for the women with LFS in the audience, I would caution that this is not an individual risk estimation. All of these analyses are meant more for a group setting when we're looking at a group or a cohort of women. So as I mentioned, there seemed to be no evidence of parity itself affecting the breast cancer risk. When we looked at the number of live births in women, this also did not seem to be a significant risk changer of breast cancer. So we had women with either no children, 1, 2, 3, or 4, or 5 live births. And then when we tried to stratify it by women who were younger or older than the age 40, we looked at women younger than 40 who had not developed breast cancer, and then above the age of 40 who had not developed breast cancer at age 40 to see if parity seemed to be a significant factor in breast cancer risk. And the summary of this is that it did not seem to affect, regardless of the age of the woman. The other thing that we analyzed was the age at live first birth, so the age at which a woman first had her live-born child, and stratified it by women who had their first live-born child at age less than 25 years, between 25 and 29, and over at least 30 years. There was some suggestion that having a first live birth after 30 may be associated with an increased breast cancer risk, but as I mentioned, this is for a cohort analysis, and it's not applied to each individual woman in the audience sitting here. So looking at the graph, I'll bring your attention to this curve. So all women start off here as not having had children. This is a nulliparous line. Women who had at least one live birth at below the age of 25 were part of this cohort line here. Women who had their first live-born child between the age of 25 and 29 were here, and over 30 are here. So if you notice just visually, this line seems very different compared to the two, and that just reflects what I said, that there is some suggestion that barely meets statistical significance that there may be an increased breast cancer risk for women who've had their first live birth over the age of 30. The other factor that we analyze, and this is, I think, one of the most common questions we're asked, apart from the hormone replacement therapy in clinic, is the oral contraceptive pill use. The IAQ recorded this with the question of, have you ever used oral contraceptive pills, or have you never used oral contraceptive pills? And if you've used them, what age did you start, and how long did you use them? So when we look at the ever-never use, as we call it, of oral contraceptive pills, just having used OCPs did not seem to alter the breast cancer risk. There was some suggestion that increasing duration of OCP use was associated with increased breast cancer risk. This has been studied also in other hereditary breast cancer predisposition syndromes such as BRCA. And as expected, women who developed breast cancer at younger ages had shorter duration of OCP use, presumably because once the breast cancer was diagnosed, they had stopped using the OCPs. And again, the difference between the LFS and the BRCA is, again, the age at diagnosis of breast cancer, where the LFS women tend to have breast cancer at much earlier ages than previously described syndromes. A caveat to our data was among the 154 women who were recruited for this study, only 25 reported never having used OCP. So this is not a great comparator group when we talk about ever-never use. Ideally, we'd like to have a big group of women who had OCP use and a big group of women who had never used OCP within the LFS cohort. And then another factor that has been studied in the general population and other genetic predisposition syndromes is the age at first menstrual period, also known as menarche. The median age at first menstrual period for our cohort was 12 years, ranging between 9 and 18. We did not see a difference in the age at first menstrual period in our cohort between women who had developed breast cancer by the time they completed the IAQ and women who had not developed breast cancer. And to look at this graphically, you can see we stratified it at age 14, so women who had their first menstrual period before the age of 14 and women who had it after the age of 14. And this stratification is what has been used in many other studies in the general population and other syndromes. And if you just look, they look visually very kind of overlapping, summarizing that there was no real difference in breast cancer risk based on when the first menstrual period was. There are certainly, of course, limitations and strengths to every study. And I wanted to acknowledge some of ours. It is a self-reported retrospective data collection. This is not a prospective randomized control study of any of these factors. The ascertainment, so these were women who had either survived their breast cancer or may not have developed breast cancer yet to be able to give this historical information. Our data did not include the time of breastfeeding per childbirth. What we report is a lifetime cumulative breastfeeding duration. And breastfeeding itself may mean different things to different women. So for some women, it may mean exclusive breastfeeding. Some women may supplement with formula. Some women may continue to breastfeed while the child is on solid foods. So this subtlety was not captured. And breast cancer diagnosis was not the first cancer in many of these women. That being said, this is the largest study that we know of to date looking at reproductive factors and breast cancer risks in specific relation to LFS. What we saw with breastfeeding it was similar to what has been published with the BRCA1 literature prior. However, I think overall it just highlights the need for continued efforts and continued follow-up with these women to see really continually how these factors continue to play out in the risk of breast cancer. So in short conclusions, our breastfeeding seems to be associated with a reduced risk of breast cancer in women with LFS. This seems to be significant with lifetime breastfeeding of at least 7 months duration. Parity and age at childbirth themselves do not appear to be independent risk factors for breast cancer, except maybe a suggestion of first live birth after 30. Age at menarche and never use of OCP also did not seem to affect breast cancer risk. And of course, further collaborative research where we have much higher power and much more attention to detail will really help kind of hone down into these daily questions that we get about how hormones and hormonal contraceptives and hormone replacement affect the biological basis for breast cancer in LFS. And this, to me, I think is one of the important slides for the families in the audience. If there's one thing you want to take away from today, it would be bullet 4, that this is still early data, and we still continue to encourage you to talk to your LFS experts about reproductive decision-making. What our early preliminary efforts show is that breastfeeding appears to be good for breast cancer risks, and it seems like the longer duration the breastfeeding, the better it is. This is not an absolute association, and there may be many other factors that may be affecting this, including prior cancer history and prior treatment. And just having a live-born child, in our analysis with LFS women, did not seem to change breast cancer risk. The OCP use is challenging to use. There are lots of things that were not explored, such as the non-hormonal contraceptive, the non-oral, so the other forms of hormonal contraceptives, such as IUDs and rings, and the composition of the oral contraceptives, whether they're estrogen and progesterone combinations, or progestin only, or depot shots. So that subtlety was not. But I think these are great follow-up analyses to do to really get into more of the detail. There's definitely a lot more to be done, and I think the dialogue around prophylactic surgery may also change how this is viewed over time. Of course, I'd like to thank the NCI LFS team, who make it an absolute pleasure to go to work every day. In specific, Sharon Savage and Maria Isabel Schatz, who have been my mentors through this entire process of LFS, and Anna Best, who performed the statistical analysis, our Westat support team, without whom our study would be nowhere where it is today. But I think the biggest gratitude goes to the study participants and families, who are such a highly motivated and actively participating group. Thank you for asking questions. Thank you for keeping us motivated, and thank you for being patient. Thank you.
Thank you very much for keeping your time. So we have time for several questions. Yes, Mr.
Yes,
Garrett
Dr.
Evans.
That was lovely. Thank you very much. Obviously, the numbers is an issue, and therefore, given that some of these factors like menarche have very little effect, it's not surprising you wouldn't have dug anything out. I think the main thing on parity to mention is that all of the older studies that showed that parity was protective was in an age when the vast majority of women had their first child before 30. The evidence is now that actually having your first child over 30 in the general population is worse than never having children. And that's also the case for BRCA1 and BRCA2 carriers. So when you look at parity now, you have to look at age of first pregnancy, because parity on its own is not the same thing. And having your first child very early gives you strong protection in the general population and in BRCA carriers.
Right. Thank you, Doctor. And we, again, this is obviously a numbers issue where, we don't have several thousands like were published with the BRCA1 and 2 literature. And even with these small numbers, I think when we hone down, there seems to be a difference. But like you said, I think we need more numbers to really kind of pull those differences apart and see if that's true.
Other questions? Yes.
So again, the numbers are small, but I'm wondering how you balance the fact that you can't screen a woman for breast cancer during the period of time that she's breastfeeding with the fact that breastfeeding may be protective. We obviously have been dealing with this for a long time in BRCA. So what do you feel, how can we balance that?
This has been an active conversation, both with our radiologists and our clinical team for a long time, because there is obviously, regardless of whether a woman is pregnant or lactating or breastfeeding, there's a definite need for screening. What has been recommended by some clinicians is that to continue to do clinical breast exams and maybe breast ultrasounds instead of doing the breast MRI. Our radiologists at the NIH very strongly feel that lactation is going to mess up what they're seeing on the breast MRI picture, so we don't screen women who are actively lactating and then the pump and dump and the contrast and all of that. But I think it's a hard balance to strike because there's no perfect answer. And then when you also look at women who are developing breast cancer around the time of pregnancy and lactation or within a year of either, what biologically is happening there. So I don't know if there's a perfect answer, but I think continuing, even if they're not getting MRI screening, continuing to have clinical breast exams and breast ultrasounds may be a good alternative.
Well, time for one last question. So if not, we move. Thank you very much.
Thank you.